My name is Matias Costa. I'm one of the Cerebrovascular Fellows. And this morning I'm with Dr. Leonardo Brasiliense and Dr. Aus Alawi, also fellows in Cerebrovascular. Today we have the pleasure of having with us Dr. Matthew Gounis. He's a professor and vice chair of research of the Department of Radiology, University of Massachusetts, Chan Medical School. He co-founded the New England Center for Stroke Research at UMass in 2006, where he and his team work to bring new imaging and medical device technology from the bench to the clinic. For more than 25 years, Dr. Gounis has performed research on the minimally invasive treatment of cerebrovascular disease with a focus on device technology, preclinical disease modeling, and image-guided surgery. In 2010, he got the prestigious YC Fang Award from the ASME, his fellow of the ASME, the founding president of the SB3C Foundation, past chair of the Bioengineering Division of the ASME, and the AHA Clinical Bioengineering Committee. He's also a member of the SNIS Foundation and serves currently as the Basic Science Associate Director for the Journal of Neurointerventional Surgery. His work is extremely extensive, very comprehensive, and extremely interesting. So we hope to really enjoy this lecture today. Thank you for joining us, Dr. Gounis. I'm going to stop sharing my screen.
Thank you so much, Dr. Costa and Dr. McDougall, for this really kind invitation to talk to you about something I'm really enthusiastic about, which is intravascular imaging in the cerebrovascular space. These are my disclosures. I've been very fortunate to work with a lot of groups around the world and industry. This particular work that I'll be presenting today was funded by the National Institutes of Health, as well as a grant from the Massachusetts Life Sciences Center. So, if we look at major advancements in neurointerventional imaging, this kind of occurs once a generation, and it begins in 1895, where Röntgen described the X-ray, which is obviously fundamental to everything you do. 1917, an Austrian mathematician described the mathematical transform, which is the basis of tomography. Of course, nothing could be done without the work of Monitz, who reported on cerebral angiography in the 1920s. 1950s, Seldinger described the techniques that you use to attain reliable and safe access to the arterial system. Charlie Mistretta, working at the University of Wisconsin, where he still works to this day, introduced digital subtraction angiography in the 70s. And in 84, Feldkamp described the practical algorithm for filtered back projection, which is the basis of any kind of three-dimensional imaging in the angio suite, such as rotational angiography or cone beam CT. And I'd like to be so bold as to hopefully say that this is the next evolution in interventional imaging, which is imaging from inside the blood vessel using a well-established technology, optical coherence tomography, which is using near-infrared light. It's very, very analogous to ultrasound imaging, but instead of looking at echoes, you're looking at near-infrared light and its reflections back to a probe. And this was described at MGH Harvard in the early 90s, where they first applied this kind of imaging to image the eye because to see the retina, because the ocular media is clear for near-infrared light. So it was an obvious first application, and it's widely used today for ophthalmological exam. The first description of intravascular imaging, where unfortunately blood is not clear to near-infrared light, so you have to clear the blood using a standard contrast injection. You can also use other substances, but it requires high viscosity in order to completely clear the erythrocytes from the field of view. And that was described in the early 2000s. And around 2010, this was FDA cleared for imaging in the coronary and peripheral vasculature. I'd like to describe to you today the next evolution, which is being able to image in the brain. This was applied to neurovascular indications at the Cleveland Clinic. They did an ex vivo study of coiled canine sidewall aneurysms, where they looked in an ex vivo fashion with optical coherence tomography equipment at the healing of the neck in response to coil embolization. At the University of Kentucky, there was the first described in the literature use of this in the posterior circulation, where atherosclerosis was treated with a wingspan stent and optical coherence tomography images were acquired. This is the commercial system today. It's originally from Light Lab that was subsequently acquired through a succession is now owned by Abbott. Now here I put St. Jude, but Abbott acquired St. Jude some years ago. And it's basically a 3 French rapid exchange catheter. It acquires high resolution intravascular images. The problem with this probe for neurovascular indications is that it has a torque wire inside of it, and that wire spins the optics at the distal end of the system. It's called the distal rotational solution. And the problem is that that's encased inside of a catheter. And so when you bend it even slightly, the wire comes into contact with the catheter and it can't spin freely anymore. And that creates what's called non-uniform rotational distortion. Essentially, imagine it's like a CT. And imagine that as you pull the bed back and you're acquiring a spiral CT or helical CT, the bed is jerking. Then you can't reconstruct proper images. Frankly, when you put it in any kind of tortuosity, like say you even got this thing distal to the siphon, there's so much friction between that torque wire and the catheter that the torque wire just breaks and renders the device useless. We went ahead, though, and used this in our animal models to see if we could image intravascular devices intended to treat neurovascular disease. And this is our first experience in a canine sidewall aneurysm, where we use this existing technology to study flow diversion in an area of an aneurysm. And what we were able to reconstruct, so this is, you're looking en face. Can you see my pointer okay?
Yes. Yeah.
Excellent. Thank you. So what you're looking at is an en face image, right? And here's the aneurysm neck. And we're creating a heat map of malapposition. So you can see here, proximal to the aneurysm, there's an area of malapposition. And around the aneurysm neck, there's some malapposition. What was interesting and kind of unexpected to us is this black area where our code kind of blew up. And that's because we were looking first for the stent and then the vessel. And what you're seeing here in black is actually thrombus accumulation on the surface of the device, creating kind of a breakdown in our code. So it shows up as a black region. But we were able to not only image malapposition, but we were able to image acute clot formation on the surface of the device. So this is work from Mayo Clinic, which we found really interesting, which is that pathologically, they could see that delayed aneurysm healing in response to flow diverter therapy, we could not see on this DSA, very nice image. It looks like the device is really well opposed, but the aneurysm remains patent. And so the question is why? And when they do histological sectioning, they could see on a histological level, looking at the cross section of the vessel, that indeed there was this area of malapposition, which is probably responsible for the delayed healing of this aneurysm. So we decided to explore that. Again, this is a rabbit elastase model. And what you're looking at is a cross section of the blood vessel. Here's the OCT probe, and this is the aneurysm. And what we see here is that we can see excellent apposition of the device at the level of the neck. And here we have what we term communicating malapposition, which, the peripheral guys would call this an endoleak, where the device is not well opposed to the aneurysm neck. And this is really happening if you think these struts here are about 35 microns. So this is really on the micro scale level. This is only about 100 micron or less malapposition at the level of the aneurysm neck. And we decided to look at this in detail. And so here you can see a case where the device is very well opposed. And here at 30 days, the aneurysm is completely obliterated. Whereas here we have a very similar aneurysm, but we have this communicating malapposition that we can measure, and I'll describe that in some more detail later. And the aneurysm is completely patent after 30 days. So we looked at this statistically, and we found indeed communicating malapposition was highly correlated and statistically significant with a poor outcome, meaning non-aneurysm occlusion at 30 days, non-early aneurysm occlusion. And then we, in this particular experiment, we did balloon angioplasty after every flow diverter deployment. And we looked at if we did before balloon angioplasty and after balloon angioplasty. And we looked at whether or not we could cure communicating malapposition performing this intervention. And so here you can see before balloon angioplasty, there was communicating malapposition. After balloon angioplasty, it was resolved. And when we look at the numbers, indeed, about a third of the time, we could improve the communicating malapposition performing the angioplasty. However, this was not ubiquitous. There was actually one case shown here where the balloon angioplasty actually created communicating malapposition. So it's not a ubiquitous solution. So here are the numbers. We found that at 30 days, it was highly statistically significant for early aneurysm occlusion in the absence of this communicating malapposition. What about looking at surface modified devices? This is a very important area. It's under an explosion right now, and it's essentially trying to hide the device from blood products using a concept called biomimicry. And here we're looking at a phosphorylcholine coated device, which is commercially known as Shield. And we're looking at now not malapposition, but actually thrombus accumulation on the surface of the device in the acute setting. So here's this angiogram, which actually things look pretty well. But then you can see on a microscopic scale, you can see areas of clot formation. And importantly, here's the vertebral artery, which is jailed by the flow diverter. And you can see platelet aggregates forming over the origin of this vertebral artery. And of course, this is a thromboembolic complication about to happen. And we came up with a really simple measurement system. We just looked at these different locations, distal to the vertebral artery, distal to the aneurysm, proximal to the aneurysm, and we just gave a score of 0 or 1, whether or not there was a thrombus present. And then we separately looked at the origin of these side branches here at this trifurcation, which includes the vertebral artery. And we asked the question, is there any thrombus accumulation, 0 or 1, over the surface of these side branches? And what we found is that this technology, this phosphorylcholine technology, is actually quite effective, regardless of whether or not we're giving dual antiplatelet therapy or not. This is the classic device, and then this is the phosphorylcholine coated device. We can see that the number of areas that we scored that where thrombus was present decreased in the presence of these coated devices. More importantly, this was a very strong relationship over the origin of the side branches, which is of course something you really care about, where we found that the majority of cases with the treated system didn't have thrombus accumulation over the surface of those side branches. And what about vascular response? This is required by the FDA prior to any device being approved for clinical use, is that you do what's called histomorphometry, which is you measure the amount of neointima that accumulates on the surface of the device. And flow diverters typically elicit a very mild intimal response, which actually is the curative event for treating an aneurysm, where this tissue grows over the neck of the aneurysm, and the aneurysm is permanently excluded from the vasculature. And we wanted to see, can we measure this using optical coherence tomography? And here you're seeing corresponding cross sections of the vessel that's been treated with this flow diverter. And indeed, qualitatively, you see a very strong correlation. But of course, we're engineers, we like to measure things. This is work done by an interventional neuroradiologist who is a Fulbright fellow in my lab, Gilles Karoff, where he made about 300 or 230 measurements using histomorphometry, the classic technique, and comparing that with optical coherence tomography. And kind of this has already been done in the coronary space, but if you look at just a linear relationship between these measurements, we found a very strong correlation, and the slope is almost 1, which means there's a 1-to-1 relationship. But if you have a gold standard technique, which is again this histology, and you're comparing it to an experimental technique, the correct analysis of Bland-Altman analysis, where we found a bias, so the inaccuracy, to be about 0.15%, and the variance, which is the precision, to be around 2.2%. So essentially what we're showing here in a quantitative way is that these techniques are analogous. So we can do in vivo imaging of vascular response, and it correlates to postmortem histology. But you say, Matt, that's all well and good, but you've already explained to me at the beginning of this lecture that we can't use this technology for imaging the intracranial space. So we set out in 2014-15 with a collaboration of a local company here in Sudbury, Massachusetts, called Gentuity, to create a neurovascular optical coherence tomography system. And these were the first thing you do when you're trying to make a new device, is you set up what's called your technical design requirements. And so obviously the first thing that we wanted is a safe system to operate in representative tortuosity of the cerebrovascular system, capable of acquiring high quality images. So that's the efficacy metric, right? Including representative tortuosity. We kind of set out that it has to be compatible with microcatheter workflow. So we need a really small system that we can put through a microcatheter. And we'd like a field of view to be at least 6 millimeters. And so this is the solution. This is the probe. It's a table mounted, or side table mounted, and you insert this, you hand this over to your technologist, they insert it into a console. It's basically, it looks like an 014 wire. It's a little bit bigger, 0155. It's got an atraumatic tip, has an optical window where the near infrared light shines through. And our idea was that you could navigate this either through a microcatheter or just by itself. And then initiate a pullback under a contrast injection and acquire 250 frames per second to image inside the system. And so here's just some examples. You get these images real time. So that as soon as you acquire the data, you're actually seeing it as it's being acquired. And the idea is to look at, particularly for flow diverters, it's an obvious first indication, to look at its apposition and thrombus accumulation, and in follow-up study the endothelialization of the device. I've been really fortunate to work on a lot of different technologies that you use every day today. And I can say this is probably one of the most studied technologies I've ever worked with from the preclinical space. Namely, we've done more than 30 phantoms that are human replicas. So in other words, phantoms that are made from patient-specific data. In vivo, we've done, actually this slide's a bit outdated, we've done about 1,000 imaging sessions in over 500 cases. And this spans a number of species from rabbits, dogs, sheep, pigs, and even non-human primates. And we've done cadavers, again, this is a bit outdated. We've done more than 4 now, but about 50 pullbacks and cadaveric models. And we published this work a couple of years ago where we describe our initial preclinical results. And one of the first problems that I was really worried about with this technology is the brain is not like the rest of the vascular systems where optical coherence tomography is used. Because of these communicating vessels, I was very concerned that we wouldn't acquire adequate flushing or removal of the blood products in order to acquire an image. So if we're injecting from the internal carotid artery, of course, with the ACOM and the PCOM, if we're imaging the MCA, there's other avenues for blood flow. And if you even have 3 to 5% of the field of view with erythrocytes, they basically attenuate the light, so you won't acquire a clear image. And so this is an example in a silicone phantom of blood that's circulating, porcine blood that's circulating, where this is not an adequate image because we're missing half the vessel. We have blood products here that's not allowing us to image very clearly. And this is an example where we have complete clearance and an adequate image. And so we experimented with different injection protocols, what it would take in order to acquire this kind of image. And we found that it was actually quite reasonable. From the ICA, about 5 ml per second. From the MCA, 3 ml per second, from the basilar, also a 5 ml per second, which when we compare to our clinical protocols for acquiring rotational angiography, it was quite comparable. And this is probably the most important image of the slide. This image was acquired about 6 years ago, where here you can see the system operating in tortuosity. We've measured, this is the brachial artery of the pig in a maximally flexed position. And we find that this actually, if you look at these curvature and radii of curvature, they're quite similar to the human internal carotid artery siphon. So we acquire these images. And what we could see is that even in this level of tortuosity, we get a completely clear image that's artifact-free. You can see the layers of the blood vessel. This hyperintensity is the internal elastic lamina. This is the media in between, and then here's the external elastic lamina, and of course the adventitia. This is the size of the probe. This is about a 2 millimeter vessel. You can see how small the probe is relative to the artery. And we also use the commercial Abbott system, and in every case with this level of tortuosity, the probe broke. And here's just an example of a DSA. This is a flow diverter implant into the internal maxillary artery of a pig. Also has a stent that's being used. And here is our high resolution contrast enhanced cone beam CT. I'm zoomed in here. Obviously, if you zoom out, it doesn't look as blurry. It looks quite sharp. And here, if you look at it, we thought this was very well posed with no thrombus accumulation. But of course, when you image at an order of magnitude higher spatial resolution, you can see malapposition of the device and thrombus accumulation along the surface of the device. I think in hindsight, you could say, oh, yeah, I can see that thrombus here. There's the hypodensity. That's probably thrombus accumulation, but we did not see that in advance. And here's just another picture of 3D reconstruction where you can see here's the stent covering this perforating vessel. And we just happened to get lucky to image where there was a breakage of this platelet aggregate from the surface of the stent, and now it's flowing down the perforating artery. So this is a thromboembolic complication happening in situ. But again, we're engineers, we like to measure things. So what we did was we took 3 reviewers. They looked at the different modalities. They scored about 1,500 images, and they just asked in a binary way, is there clot formation on the surface of either a flow diverter or a stent? And is there malapposition of the flow diverter and the stent? And you can see here with optical coherence tomography, what we call high frequency optical coherence tomography, there was excellent agreement across all categories. What was interesting is that when we looked at DSA for clot formation on the surface of the stent, there was actually pretty high agreement. But what was interesting is if you accept, based on what I've shown you, that this OCT information is the ground truth, although the reviewers agreed with each other, they were only right about half of the time. So basically the toss of a coin. Going back to communicating malposition, now we have really high resolution imaging. The axial resolution is approaching 10 microns. It depends on the settings, how you get the Z direction resolution. We can image as high as about 40 microns, and that depending on how you acquire the data. But we decided with this system, can we actually measure it? And again, here's just showing you the point in this rabbit aneurysm that's not cured. If you look at the scanning electron microscopy, you can see that areas where the device is not in contact with the blood vessel wall, there's no endothelium growing over the surface of the device. Whereas when it's in contact with the vessel wall, there is a neointima. And again, just showing the point here with the communicating malposition, there's still a patent aneurysm. And when there's excellent apposition at the level of the aneurysm neck, this is the aneurysm, you see a complete cure of the aneurysm. And so we measured this very simply, right? We take an area on each slice and we sum it over the level of the neck. This is the area of malapposition, and that gives you a volume if you sum it over all the different slices. And then we also took a normalized arc length and we looked at the amount of malapposition as a function normalized to the aneurysm neck. And we looked at, and that basically accounts for the size of the aneurysm neck. And then we create a normalized area or ratio. And what we found is it's actually incredibly predictive of early aneurysm occlusion. So if we use this threshold of volume around 0.6 millimeters cubed, we have 92% area under the curve. So very highly specific and sensitive for predicting complete aneurysm occlusion. And this arc length actually was even more sensitive, 69% malapposition correlated with prediction of early aneurysm occlusion. And again, I'd like to go a little bit more into the surface modifications. As you all know, this was described more than 100 years ago, how thrombus accumulates, and it's has to do with the blood products themselves. Vascular trauma basically reveals the subendothelial matrix, which is highly thrombogenic, and then circulatory patterns, especially low oscillatory wall shear stress, can lead to thrombus accumulation. And the first problem, of course, is that when you introduce a foreign body, that's going to be recognized by blood products and cause accumulation of thrombus on the surface of the device. And so the standard approach right now with a variety of products on the market is to hide these endoluminal prostheses from those blood products using either sugar or fats, basically bound to the surface of the device so that they don't react with the blood products. But that doesn't solve the other problem. And here is a picture of the anterior spinal artery of the dog. And you're looking at an en face scanning electron microscopy image. And what you see here is removal of the endothelium. And if you look at this pattern and measure it, this is actually where the microcatheter was navigated through this vessel. And this is where the microcatheter stopped. You can see this edge. And then you see a thinner profile of endothelial denudation. And that's where the microwire was navigating this catheter. And if you zoom in, of course, you can see removal of the endothelium, exposure of the subendothelial matrix, collagen von Willebrand factor, and of course the platelets react to this. I'll skip this. There's different approaches. I want to introduce a new approach, which is I have an old idea from cardiology, which is to not only hide the device from the blood products, but also to be active. So this is where you can covalently bind heparin to the surface of the device. And what this does, it activates antithrombin. And when you activate antithrombin, you inhibit thrombin formation and, and you not only deal with the extrinsic pathway of the coagulation, but you also deal with the extrinsic pathway. So you're solving both the problem of the foreign body and the vascular trauma that you're inducing. And this was studied in cardiology, as I had mentioned. This is pre the drug-eluting stent era. When they took this covalently bound heparin, they put it in patients, and they only gave them for coronary atherosclerosis, and they only gave them aspirin. And they found that indeed in this clinical study, the heparin coating provided protection against stent thrombosis. There were only 2 cases, by the way, of stent thrombosis, and both of them had extrinsic factors. One patient had traumatic chest injury, and the other patient had a coagulation disorder. So we've studied this. This is a product made now by Stryker. We looked at the Evolve stent with and without the heparin coating in blood flow loop models. And we found indeed this active coating really prevented thrombus accumulation. But these blood flow loop models don't address that other problem I mentioned, which is the vascular trauma. So we decided to test this in vivo. And this is work done by Vania Agnosticou in my laboratory, where we implanted overlapping flow diverting stents in the basilar artery of the dog, and we didn't give them any antiplatelet medication. So you can see this is a very aggressive model, 1.3 millimeter intracranial vessel with overlapping flow diverters. And what we did was we looked at high frequency optical coherence tomography, acute thrombus accumulation on the surface of the device. Then we did weekly MRI, DWI flare, and subtly weighted imaging. We did neurological exams, and then we did neuropathology at the time point. And I'm just going to present these with no dual antiplatelet therapy, the bare coated or the bare stents and the heparin coated stents. And what we found is, here's just a typical example. Of course, here's before implant, after implant. This is with an uncoated device. At 60 days later, we have a mid-basilar occlusion. Interestingly enough, these animals were asymptomatic. We can see the optical coherence tomography. We see thrombus accumulation over the surface of one of the perforating vessels. And here, the histopathology on follow-up occluded, as I had mentioned. And then we found, interestingly, these septally weighted lesions at multiple time points, all the way to 8 weeks following the implantation of the device. And here's a representative coated case where the vessel remains patent. No thrombus, a little bit of thrombus here, but no thrombus over the origin of side branches on the acute optical coherence tomography. A very nice vascular response, and only one of these septally weighted images post-implant, none on follow-up imaging. What was unfortunate in the study, and I think we were a little bit too aggressive with such a small vessel and no dual antiplatelet therapy, is that we had roughly equivalent numbers of basilar occlusions in both groups at the terminal follow-up. But what we found that was interesting is that if you looked at the TOF, which was repeated every week, if the basilar tip was present, this correlated perfectly on follow-up angiography with a patent basilar artery. However, if the top of the basilar was not present on TOF angiography, that correlated perfectly with a mid-basilar occlusion. And so if we accept this imaging surrogate point, which was done routinely, like I said, weekly following implant, we did see that occlusion with the coated device, which is the blue line, was delayed to 2 weeks, whereas all of the cases of uncoated devices, the occlusion occurred at 1 week. Another interesting thing that we looked at is if you measure across all the groups, the amount of clot formed in the acute setting with OCT on the surface of the device, and the presence post implant of these septally weighted lesions, you can see nearly a perfect correlation, which was highly statistically significant. So more clot formation on the surface of the device, more of these septally weighted artifacts were present. And then another interesting finding was that if there was a flare abnormality, which is seen here, all of the flare abnormalities were related to the presence of, either in the preceding imaging study or in the concurrent imaging study, were correlated with the appearance of these septally weighted artifacts. And then one highly statistically significant result that we achieved was that the coated devices had fewer of these septally weighted lesions at all of the imaging points after the implant. So at 1 week, 2 weeks, 3 weeks, 4 weeks, and 8 weeks. So the coating does reduce these septally weighted artifacts, which we think are related to emboli. What about intrasaccular devices? I'm just showing you this picture. This is a canine bifurcation aneurysm that was coiled. And we took, this is the actually in situ, you can see we did a balloon occlusion proximally. We flushed contrast, and then we acquired the OCT image. And I thought this was, in the working projection, this was, not an unreasonable result, maybe a little bit of a neck remnant. However, you can see on the OCT, there is a herniation of the coil. This is the coil, this high intensity object that creates this big shadow. This is a coil, which is really in the lumen of the vessel, and this is the acute clot formation on the surface of the stent. Now, I would say if you had these data intraoperatively, you would change your course of management. And then we decided to look at some of these new intrasaccular devices. This was called the Medina at the time, and there were not case reports, or actually case series that showed really excellent results with lasting durable occlusions. And then there were other reports or case series where indeed, there was recanalization of the aneurysms. And so the conclusion was you can't just use one of these devices, you need multiple devices. And so we decided to try to really study this and understand what was happening. And here's a case, canine bifurcation aneurysm again. You can see this gap at the level of the construct, at the level of the neck. And this is actually where the microcatheter was used to position the device. The device was deployed, and then the microcatheter withdrawn, leaving this gap, and this corresponded with recurrence of the aneurysm. Here, this, by the way, there were two devices in this aneurysm, and we still had this gap. Here we used a single device, and I have to say, post-operatively, I thought this was a terrible result. But when we look at the intravascular imaging, we see complete reconstruction of the aneurysm neck with none of these gaps, and this led to a complete occlusion of the aneurysm. And like I said, we like to measure things, and what we found is that just having a small 1 millimeter squared gap at the level of the neck was predictive of treatment failure. And again, this was statistically significant. And we compared our OCT measurements of this gap with optical coherence tomography and scanning electron microscopy, and we found a very strong agreement. And what I like very much about this technique is that here you can see this is a sidewall aneurysm in the dog that's been treated with one of these devices, and you can follow over time 7, 30, 90, 180 days in the same animal. You can follow the gradual healing of the aneurysm neck. I think this is very important because the FDA requires us to euthanize animals for new devices at each of these time points and perform histology. And I think with this technology, we can forego that and use the same animal to longitudinally study aneurysm healing. This is work by a former fellow, Zainab Fardar, who looked at, here I showed you a Medina device before, now we're going to implant a web device, and we're going to study the healing at the level of the aneurysm neck pursuant to the treatment of using a web. And what we found over time with follow-up angiography, that only about 5 of the animals out of 24 at 12 weeks had an adequate aneurysm occlusion using the web scoring system from Dave Fiorella. And really, it's quite counterintuitive. We looked at the apposition at the level of the neck, and we looked at herniation. And what we found was that adequate apposition was achieved with only one side being in complete contact with the aneurysm neck. It didn't require both sides. But what was really interesting to us, and I'll show a higher mag image, is that herniation really caused delayed aneurysm healing. And again, this is kind of like the malapposition story. When the device is herniating into the main streamlines of the flow of the artery, it's much more difficult for that scaffold, that neointima, to form over the surface of the device, which leads to delayed aneurysm healing. As you can see here, the aneurysm remains completely patent. And again, creating mathematical models, we found that this herniation and our definition of apposition was really pretty sensitive and specific, around 88% of predicting early aneurysm occlusion. And again, I hate to belabor the point, but you can see here when you compare the coverage predicted by optical coherence tomography and that done with scanning electron microscopy in a postmortem setting, you have a very strong relationship. 96% of the variation of the data is described by a linear model. And interestingly enough, the slope is 1. So it's almost a 1-to-1 correlation between intravascular imaging and ex vivo preparations. I think that this technology has a really important role for studying intracranial atherosclerosis, which the progression of ICAD is actually very poorly studied for the intracranial system, not like for the carotids in the heart, where you have access to specimens due to things like endarterectomy and coronary bypass, and you can really study the progression of these diseases. Unfortunately, in the brain, that's not been possible. And so what we're doing here is we're imaging cadaver specimens of intracranial atherosclerosis. And we're looking here just at different kinds of plaques. Here's a fibrotic plaque. Here's a plaque with a big lipid core. It has a dissection. And here is a plaque of calcifications. OCT is excellent for looking at microcalcifications. And then we had an independent pathologist characterize these plaques using the standard histological techniques. And what we found with the blinded pathologist and the rater looking at the optical coherence tomography had a 1-to-1 agreement regarding the plaque composition. What about luminal narrowing? I attend our clinical conferences every week, and I think every week there's at least one case where we're discussing some sort of stenotic lesion, and the underlying etiology of that stenosis is a difficult workup. And here I'm just showing some cases in animal models where here this is the basilar artery. I'm sorry, it's the anterior spinal artery. And then this there's some spasm in this anastomosis between the vertebral artery and the basilar artery. And you can see here, this is clearly vasospasm. What you have is concentric thickening of the smooth vessel cell layer. That's now squeezing this probe. This is the optical coherence tomography probe. And here is a case of an aneurysm that we were coiling. We saw in angiography something suspicious. We did our intravascular imaging. We clearly see an intimal dissection, which over the course of 1 week, now we have the false lumen with blood products inside the false lumen, and here's the true lumen. So you can study the origin of this stenosis with a different pathology. And also, I'd like to mention that, we've translated this technology. Before the talk started, I was discussing with the team. 25 patients have been enrolled with Dr. Pereira in Toronto and Dr. Lilik in Buenos Aires. And we can also study vascular inflammation very well with optical coherence tomography. This was something that Dr. Anagnosticou had done, which is imaged through the intracranial arteries in dogs and then map the structures of the subarachnoid space. Unlike cardiology, where the vessels are much thicker, and then there's often disease, it's hard to get good penetration. But here in the cerebrovascular system, the arteries are quite a bit thinner, and the penetration is really spectacular. You can see the structures of the subarachnoid space. Here's the arachnoid layer. This is actually brain parenchyma. These are the subarachnoid trabeculate. And we can map these in 3 dimensions. And I think that this is really important for the studying of a number of different diseases, not just cerebrovascular pathology, but looking at things like communicating hydrocephalus. Also, brain trauma. It's important to note that no brain trauma models include the presence of the subarachnoid trabeculate, which are the mechanical scaffolding of the subarachnoid space. And you can see here how they attach to arteries. We can see them attached to veins. We can see them attached to the nerves. And it's just a nice picture of the basilar artery. You can see the origin of the pontine perforators. And here again, you can see the subarachnoid trabeculate attaching the basilar artery to the arachnoid space. And then we can image dynamically as well. I mean, it's limited in that you're only getting a single 40 micron space, but you can see, I'll play this again over the cardiac cycle. You can see how these structures are moving. And in engineering terms, that means I can calculate their strains, which is a way to get ultimately to the stiffness of these structures. And here you can see over dynamic imaging the motion of the subarachnoid structures. And we've done this as well in cadavers. And now, like I said, we've done it in vivo with humans, where we can see very nicely in the middle cerebral artery the structures of the sylvian fissure. And it's just a reconstruction. This is the posterior cerebral artery, 3-dimensional reconstruction of these subarachnoid structures. So how do I think this will ultimately be applied? I think characterization of the pathology is one of the first obvious indications. We can see a lot of things. What's really interesting is that I've always read or assumed that intracranial atherosclerosis is actually a rare disease in our populations. And what we found in imaging the cadavers and now subsequently humans is it's actually much more prevalent. It can be non-stenotic, but we see a lot of sick blood vessel walls. It's very high resolution. So I think for device sizing, it's going to play a very important role. Typically, we use rotational angiography, which is actually one of the worst techniques for measuring a blood vessel because the data are acquired over 4 seconds and you have pulsation of the vessel. And you get a partial volume averaging. And also, it's one of the least, in terms of spatial resolution, one of the least, the poorest spatial resolution techniques that we have. So I think device sizing, it's really going to help, especially with some devices, you have 1/4 millimeter codes. It's going to help you more accurately size devices. Monitor acute and chronic vascular response to the treatment. We found that we can vary with high sensitivity and specificity image thrombus accumulation, especially over the origins of side branches. And in our current paradigm, we often at our place kind of wake the patient up after a flow diverter treatment. And, that anesthesia period, they're kind of goofy. And then we find out they're actually having a stroke. And then we have to bring them back and give intra-arterial agents to break that clot up. Here we can see them during the period. And I think we can, as I've shown you, I hope it's convincing, prognosticate outcomes, for example, measuring that communicating malposition, looking at the herniation of devices that are intrasaccular, and prognosticate outcomes and prevent complications. So I'm very fortunate I get to, talk to folks like you about this technology. but this is the work of a huge group of people, especially Dr. Ajit Puri, who's my clinical collaborator, my partner and wife, Vanya Anagnostikou, a former Ph.D. student, Robert King, who's now on our faculty, has done a lot of this work, and Giovanni Ughi, who's adjunct faculty and also the director of advanced technologies at Gentuity, who's helped develop this technology. But we've also worked, of course, with people around the world, Pedro Lilic and Vitor Pereira, Demetrius Lopez, and others, to bring this technology from the bench to the brain. So with that, I hope this was interesting and would love to entertain your questions.
Thank you so much, Professor. It was an amazing talk and really something totally new for us. Dr. McDougall, would you like to start with a few comments or questions?
Yeah, it's just so spectacular. You've opened up another dimension. It's like, we're peeking through the door into this new dimension that will just, change everything we do. And it's a little bit overwhelming when I see that level of resolution and start thinking about intraoperative decisions and how you're deciding where the new limits are. We're going to be frightened to see a lot of the things that we thought were, excellent results. And, I'm really just wondering how we roll that out and how we figure out where those new lines and boundaries are. And of course, the implications for device design are just, staggering.
And thank you, Dr. McDougall, for that. It's funny, I was in a meeting with all the chairs 2 weeks ago, and we were talking about how to train radiology residents with some of the work that my chair, Max Rosen, has been doing about perception and about making errors. And one of the things that was interesting was that they use pigeons to train to look for CT nodules, right? And what they found is that training people on what's normal versus abnormal actually has better outcomes. And one of the people said, well, is there abnormal studies? And my chair's response is, with the imaging that we have today, no, there's no abnormal. The question is to say which is clinically meaningful. And that's the same problem we're approaching here, because we're imaging at such resolution that to make this clinically viable, we have to say what's really a problem, what's not a problem. And so that's one of the things we've been working on for about 5 years now, is using, of course, like everybody, an AI pipeline, which basically quantifies everything. Because in the clinic, when you're doing a case, I now am producing for you 500 images for you to study that you've never seen before and that you have difficulty interpreting. And with OCT, I didn't mention, there's a number of artifacts that you have to be aware of. So what we're trying to do is train computers to give you quantitative information that can make clinical decision-making easier. I don't know if that's helping answer your question, but yes, there's a lot of work to still do.
No, I think that was actually, of course, where I was going to go next is to ask about how you were going to incorporate this to AI, because that it does seem like there's more information than we can sort of humanly process and manage in real time. I'm just going to deviate just a little bit, just to sort of think about how this gets rolled out. How close are you to having the FDA, for example, accept this and save thousands of animals?
Oh,
I know that's a little bit tangential, but it's actually, kind of really impactful and in terms of cost, in terms of acceptance of what goes on in labs and things.
Yeah, I'm actually really passionate about that. That's going to take some time. The agency is under always, of course, a lot of oversight, and they're very cautious, as they should be. And I think we just continue to generate high quality data, like I showed you, looking at intimal hyperplasia, and we've measured it, and continuing to generate data like that, showing that it is equivalent to gold standard techniques. And like I mentioned, one of the things that we're really interested in the FDA is as well is what kind of vascular inflammation do you induce with different device coatings, for example. And OCT is actually a really good tool. I haven't showed you data on that today because it's still too new, but it's really good at looking at inflammatory responses. So I think we just continue to generate that data and drive acceptance from the scientific community, and that will help the agency make that decision.
And then you mentioned, of course, that you're starting to use this in human studies in real time, obviously outside of the jurisdiction of the FDA. What's the timeline? What's the rollout? How does this get into everyday use?
It's a great question, and that's currently something that we're very passionately pursuing. Because I do think this really has a transformational role in the work that you and your colleagues do every day. I can't give a precise timeline right now. It's kind of deciding how that regulatory process would look. I can just tell you, traditionally from the coronary system, it was actually a relatively simple pathway for FDA approval. And it was a 50-patient study where we had to demonstrate that you could clear the vessel and acquire what's called artifact-free imaging. So basically that you can image safely and just image the vessel and do that with no blood present. And then that was approved by the FDA. I don't know for neuro. I mean, I assume that would be the path forward, is to show that we can image efficaciously and safely, of course, but not to make any conclusions as to what you do with that information. That's beyond the scope of the technology.
Right, makes sense. And in terms of our ability to use this information, what you're learning for flow diverters, for intrasaccular devices, how has it changed practice in your group?
So I can just, Vitor and I presented this at Val d'Isere, so I can refer to those particular cases. One case was a recurred aneurysm. It had previously ruptured, was coiled more than 10 years ago. It recurred. They used a solitaire stent and coiled behind that, and it recurred again. And the plan was to go in and put a flow diverter. We acquired the intravascular imaging, and what we saw was we could never, or Dr. Pereira could not do that because both ends of the stent were very well endothelialized, and the remainder of the stent was like a ribbon inside the blood vessel. It was not in contact with the blood vessel wall. So of course, conservation of mass dictates that if you're going to now put another endoluminal prosthesis and expand that to the wall, you would cause significant vascular trauma where it was embedded at both.
Right, shortening.
He changed the treatment plan. So then he just went microcatheterized the remnant and coiled it. So I think that's where it's going to have a role, is to help us guide treatment planning, as well as the other things I mentioned. Studying the intracranial atheromas has just been eye-opening.
Yeah, you showed in the animal model the balloon angioplasty, or and increasing the percentage of wall apposition. How much force were you inflating those balloons with? And is that something that your group is incorporating now, is to routinely doing angioplasty, or is that too early for prime time?
So it actually only cured about a third of the cases with communicating malposition. And like I said, in one case, it created it. So it's not a ubiquitous solution. Right. It is something that we use clinically when we detect on our existing like vaso-CT data. We do balloon angioplasty. We retrospectively reviewed our data. Cases where balloon angioplasty was used actually did have a higher rate of complete occlusion at 6 months. But I'm not saying that's the answer, because obviously you also cause more vascular trauma, and that can create more thromboembolic complications. In our particularly retrospective case series, it did not, but it theoretically could. We used a compliant balloon. I believe it was a transform. And so I don't know what the pressures were, because it's really just a volume base. But, we
right.
fully expand.
Yeah. I don't want to hog all the questions there, Matthias. Do you have?
Yeah, Leo, you want to start with your question?
Hey, Dr. Gounis, thank you so much. This was an incredible talk. Had a lot of fun watching you talk about technologies. My question is, I was, trying to think of like interesting applications, and I'm sure this has come up before for you guys. I was imagining a scenario where a patient has a questionable aneurysm, and the patient, is going from a CTA to an angiogram, so increasing the accuracy, increasing the resolution. I was wondering if do you foresee that OCT make to this where it would be used as a diagnostic study, not for the whole vasculature, but for an area of interest? For instance, there's an angiogram, and even though the angiogram has high resolution, there are instances sometimes where maybe the aneurysm could be too small, even basically not even on the early stages of formation. But since OCT has such a high resolution and such such a defined focus, I wonder if you'd be able to see things that even an angiogram would not be able to detect, just from a diagnostic standpoint.
Absolutely. So we imaged recently an aneurysm case where that was ruptured, and we could actually see the rupture point, and we could see the clot formation over the rupture point. So I think that has therapeutic implications. And if you have to do a suboptimal treatment, depending on the situation, you don't want to use an endoluminal prosthesis. It can really help you target your treatment. We had a case recently of a lenticular striate aneurysm, very, very small aneurysm. It's probably only 3 millimeters. I guess if you're a true believer, or not a believer, but you follow all the data that we currently have, you would say, do I treat, do I not treat? When we imaged that aneurysm, we saw very nicely the whole wall of the aneurysm. And there was an area of the aneurysm where, I'm embarrassed to be saying this to neurosurgeons because you guys see this every day, but there was an area of the aneurysm wall that was less than 20 microns thick, completely hypocellular wall. And then you could see immediately behind that the brain parenchyma. I think when you see an image like that, it can really help you guide your treatment decisions. We've seen thrombus accumulation along the surface of the device, and it really looks like with some inflammation behind it. It looks like really proteolytic enzymes digesting the wall of the aneurysm behind the thrombus, which has been very well documented in the AAA literature. So we're seeing things that you can't see with an angiogram, a CT, or even. I'm not, and I probably shouldn't say this to a group in Seattle, but I'm just not a big fan of what we call vessel wall imaging. You're imaging structures, that I've shown you, like we had that wall that's 20 microns thick. When you take a 400 micron voxel on an MRI, are you really imaging the blood vessel wall? So, I think this is true vessel wall imaging.
Wonderful. So yeah, that leads to one of the questions. So what do you think are the difference with vessel wall imaging apart from resolution?
Excellent question. I can tell you there's some early work in the coronary system where you can use fluorophores. So you can basically use optical contrast agents that have peptides or antigens that bind to certain things, cellular components. So you can really, it sounds crazy, but it's like almost doing in vivo immunohistochemistry. Now, this is very futuristic, but I think that would be a spectacular development for true highly specific and sensitive vessel wall imaging. And again, I don't want to insult you guys because there's great work being done on this, but when you give a gadolinium contrast agent and you're looking at aneurysm enhancement, there's so many mechanisms for that to enhance. So I don't believe that's a highly specific marker for any kind of aneurysm vessel wall imaging. There could be thrombus inside the aneurysm, which is permeable to contrast. There could be atherosclerotic plaques within the aneurysm that have neovascularity that take up the contrast. And the group in Amsterdam has shown that even certain flow conditions can lead to contrast accumulation inside the aneurysm. So is it really what everybody thinks, macrophage inflammation imaging, or is it really imaging a whole bunch of different things and throwing them all into the same bucket? And I know that's very controversial, and I'm happy to take some heat for it.
Another question is, do you think we could do it with this technology? Do some kind of longitudinal study and predict aneurysm growth based on certain baseline characteristics of the aneurysm that we see? Do we get that resolution too?
Yeah, I'm going to have to punt on that one. I think we're going to need a lot more data, and we're going to need predictive models, but that's obviously the future that I envision, and hopefully before my retirement.
Okay. So what is so far the smallest microcutter that you can use for this device? Is it 017?
Excellent question. And that's a little bit hard to answer as well. And I'm going to answer it from my perspective as a researcher. So the smallest catheter I routinely use, to be honest with you, to go very distal into the vasculature of these animals is a Headway Duo, the small one, the 0165. The problem is that you can't pull the OCT through the microcatheter. There's too much friction. So what I do is I lock the whole system and I actually pull the microcatheter back with the OCT probe exposed. Obviously, that's not a clinical indication. Routinely in our clinical studies, we've used phenoms, both 021s. 021 is ideal. The problem that I just want you to be aware of is that if you use the larger microcatheter you use, now you still need to clear blood through whatever distal access or guide catheter you're using. So the bigger microcatheter you use, that requires you to use a bigger proximal contrast injecting conduit. So if we use an 021, we typically use like an 072 Navion or Sophia Plus or something like that.
Okay, and how much contrast do you need to map like a regular?
So I can actually
let's say,
very precisely answer that question in our clinical experience, which again is very early days. So we tend to inject more contrast than is actually needed just because we want to allow complete clearance. But our average in the last 10 cases, I think our average was 18 cc's per acquisition. And I'd like to remind you that you can acquire these data at the exact same time you're doing your rotational angiogram. So I think that further reduces the total contrast that the patient sees.
okay. Did you use the system? What do you think about the use of this system for venous, from the venous side?
I'm so glad you asked that question. So Vania has been looking at that in cadavers. It's really, really tricky. We've done that both in vivo and in cadavers. Cadavers, it's been easier. With animals, the problem is blood clearance, of course, and the size of the structures. So we don't have any human in vivo data, but in our ex vivo studies, we were able to do it. But optimizing the contrast injection is going to take time. We actually found the best was injecting intraarterially and imaging during the venous phase, but we had to give a lot of contrast in order to acquire those images. So it's a challenging problem, but something that we're very much looking forward to solving.
Okay. So you mentioned the applications for example, for MPH or any kind of communicating hydrocephalus. Did you think about the application, for example, for leptomeningeal spread or any other?
Leptomeningeal spread, no. I'd have to learn more about that. What I do really want to use it for, and we have tried but unsuccessfully, is looking at neurovascular compression disorders. So trigeminal neuralgia, for example, where one of the theories is that the pulsation of the artery is causing the nerve compression. I think with this technology, as I've shown you, we can see through the blood vessel wall and we can acquire dynamic images. So I think this is very well suited to study those diseases, because I think in true cases of neurovascular compression, there's other, and there's many groups looking at this, there's other approaches rather than surgery or injection of things. Maybe you can change the course of the artery, or you can change its compliance with an endoluminal prosthesis. And that could be an endovascular treatment for those disorders. That's something that thrills me and my group right now, is looking at fringe applications of endovascular techniques. And I think actually the field really needs it. I think you guys could use more elective procedures rather than just treating acute strokes all day. So that's one of the things that we're doing a lot of work in drug delivery. So we've treated 8 babies with Tay-Sachs disease using microcatheterization through a lumbar puncture of the intrathecal space and going up into the sternum magna, the cerebellar pontine cistern, and delivering drugs. In this case, gene therapy, but for ASOs and other siRNAs, using neurointerventional techniques to treat neurodegenerative disease is something that also really excites us.
How far can you get in the subarachnoid like distance from the vessel wall? You know what I mean? Like, what is the maximal diameter around the
the field of
OCT?
view? Yeah, we're measuring between 7 and 8 millimeters from the probe.
Okay.
So I think, again, for veins, that's going to be a real challenge, but for imaging the subarachnoid space, it's quite a bit of
yeah. For example, some procedures like ETVs, for example, you make a hole in the floor of the third ventricle, and sometimes you can't predict how the patient is going to react to that. You can study the the subarachnoid webs and all the subarachnoid membranes that you cannot see in regular images.
Yeah, and that's
and
what,
see.
what's just brilliant about this is that the cerebral spinal fluid, as I've shown you, is really good for near infrared light imaging. That's been for third floor ventriculostomy. I just want to point out though that we're a side-looking probe. We're not looking forward. And to do a forward-looking probe would be a completely different technology. So.
Yeah, but if you put in the Vascular, you can see on
Yeah.
the sides and see, you know, that's the place where the ATV is going to go.
Absolutely. And we really like to study this for the E-shunt procedure.
Right, for the shunt, for example, to localize the base placement. And my last question is, one of the appealing indications for vessel wall imaging is like RCVS versus vasculitis, for example. Do you think we can get to this?
We need to collect those data because I swear it's every week, and I don't know if it's the same thing at your practice, but you know, young person with these weird beady vessels and the diagnostic workup of those patients is not a simplistic thing. I know you guys do biopsies and, you know, you try to, you look at CSF and protein profile. I mean, it's really a challenging workup. So I'd really like to acquire more of those data. I can tell you we've recently done a vasospasm case and it was fascinating. You can see it was post-subarachnoid hemorrhage vasospasm, and the vessel was just angry. I mean, it was the concentric intimal thickening. The internal elastic lamina would look like a serrated knife. It was really interesting. So we just have to keep acquiring these data. And I think when we, and by the way, atherosclerosis, not atherosclerosis, is all different kinds of plaque compositions. And so optimizing medical management and interventional approaches, we just need to keep studying that. It's eye-opening.
Right. Okay, thank you so much. Those are my questions. And
can I flip the question? So again, this is an invasive procedure. What's your enthusiasm for using this in your practice? Again, noting that it's invasive. It requires, you know, microcatheterization of these small vessels.
I think personally, Dr. Madhuga can also give an input, has more experience, but I think personally it will also depend a lot of navigability of the system and, you know, further study on any thromboembolic complications from friction with the intima and, you know, technical. And of course, cost related.
It's not cheap. It's not cheap, that's for sure.
Yeah. You know, if you didn't show all these beautiful images of intimal trauma, I would have said, you know, this is, you know, we navigate there all the time with, you know, practically without risk for just navigating, you know, in normal arteries. Then you go and show me all the intima that I'm stripping away. I'd love to see that used to really improve people's technique, because you do see the whole spectrum of people's catheterization techniques in terms of elegance versus aggressiveness, and I think we would all change our practice if we saw some of those pictures. But the risk benefit for the images that you're showing us and how that will change our decision making, I really have enormous enthusiasm for this and all we're going to learn, and I really share your excitement for it. I think it's going to be amazing.
Yeah. Thank you so much, Professor, for being with us.
Wonderful spending time with you this morning. Thanks so much for sharing it with us.
Again. Yeah, thanks for getting up so early.
Thank you so much.
Pleasure. You take care.